Hello and welcome to the Imaging Wire Show. My name is Brian Casey and I'm managing editor of the Imaging Wire. It's really great to be with you today. Our topic is analyzing Medicare's proposed 2024 rates and rules. And our guest is Sandy Coffta. She is Vice President of Client Services at revenue cycle management firm Healthcare Administrative Partners. Sandy, thanks for being with us today.
Thank you for having me here, Brian.
So Sandy, can you tell us a little bit about yourself and a little bit about HAP USA and what you do?
I have been with HAP for about almost 24 years now. Have been worked my way up from data entry all the way to vice president. And HAP is a radiology revenue cycle management company. Been around since 1995. Radiology is all we do. And we love being thought leaders and providing education to the groups that are out there.
Awesome. So you work with radiology practices, you help them manage the revenue coming in, and you keep them abreast of different regulatory changes like what we're just about to talk about.
Yes.
Perfect. So this month, CMS, that's the agency that administers Medicare and Medicaid, announced new rates and rule changes for 2024 for both Medicare and Medicaid. Can you talk a little bit about the process that CMS uses to set these rates and where what happened this week fits into all that?
So the Center for Medicare and Medicaid Services every year drafts the proposed rule, which is reviewed by the Office of Management and Budget. Following their approval, the proposed rule becomes available for public viewing through the Federal Register. Right now, we are in a comment period between the proposed rule and the 2024 final rule. Comments are due by the end of the day on September 11th, and the final rule is typically published in early November.
Now, this current rule or this set of rules that just came out, what parts of the Medicare system does this apply to?
The Medicare Physician Fee Schedule proposed rule applies to physician and other practitioner reimbursement rates across all medical specialties that serve Medicare Part B patients. Beyond the payment rates, the proposed rule includes updates to Medicare's value-based care system, such as MIPS, and there are also changes to the appropriate use criteria program, also known as clinical decision support.
Okay. Now, what were some of the main changes that Medicare proposed? I guess there was a change to every year they go in and they adjust things like the conversion factor and all that kind of stuff. And just kind of in layman's terms, can you talk a little bit about what that is and what they proposed for 2024?
The most critical change is, as you mentioned, the conversion factor. That is the dollar value Medicare uses to calculate all of the Medicare Part B fees. For 2024, they're proposing to reduce the conversion factor by 3.36% from 33.89 to 32.75. In addition, there are the typical RVU adjustments to various CPT codes, some up and some down, that will impact reimbursement, and adjustments to the geographic price cost indices, which set Medicare rates by region.
So 3.36% doesn't sound like a ton of money, but it's kind of like every year we seem to go through this same kind of song and dance where CMS proposes lower rates for physicians. And, it based on my anecdotal, knowledge, it doesn't seem like Medicare pays a lot. Why does CMS continue to drive Medicare rates down?
This is primarily driven by Medicare's mandate to stay budget neutral. They have to pay for more services with the same pool of money. And obviously you can't pay out more than you have. And we kind of joke that the old line, there are only two certainties in life, death and taxes. We need to add Medicare Physician Fee Schedule decreases to that list.
And so how much of an impact do you think this 3.36% reduction is going to have on physician practices?
It's across the board. It's probably across the board. It will be about 3.36%, but there will be, as there are every year, winners and losers. Radiology is expected to have a total decrease around 4.25% as a result of those RVU shifts. Other specialties may actually see an increase of reimbursement, endocrinology and family practice in particular.
So is CMS kind of trying to sort of, I don't want to use the term reward, but is it trying to kind of shift money from certain areas to other areas by doing this kind of thing?
Yes, definitely. There's been a focus in the last 2 or 3 years on increasing primary care and family practice reimbursement.
Interesting. Now, CMS also proposed some other changes to rules that govern how it pays for Medicare and Medicaid services. What were some of the major points of those?
A lot of the major area would be the MIPS program. We have 2 commonly used radiology quality measures slated for removal.
And MIPS is the quality improvement program?
Yes, the quality improvement program. They are eliminating the measure for CT dose reduction and for nuclear medicine comparison studies. They're also increasing the number of points that you need to avoid a penalty. So while they're taking away the opportunity to earn points, they're increasing the number of points you need to succeed, which is obviously a huge concern for radiology.
Sure. Now, I understand there's also been a proposal to pause the implementation of appropriate use criteria. And so what CMS had been doing is trying to get referring physicians to use appropriate use criteria and software when they're ordering advanced imaging like CT and MRI. But they keep saying, hey, we're going to start requiring this by this date, and then they keep pushing it back and back and back. And it sounds like it may be dead. What's happening now?
I think that this iteration of appropriate use criteria is on its deathbed. The penalty phase was paused multiple times. Last year, they delayed it indefinitely, not just a 1 or 2 year push. This proposed rule takes that a step further by ending the testing and education period. There is still a small chance that pressure from software companies heavily invested in AUC could keep the testing period open, but it's unlikely that the program will be implemented in its current form. But what I will say is that CMS very clearly states in the proposed rule that they see value in AUC. ACR backs that position. So I would expect we will see a new version of AUC surface within the next few years.
Okay. Now, CMS also proposed some changes to radio tracer reimbursement, and can you detail some of those?
Primarily, that is reporting waste of radiopharmaceuticals, whether if there was no waste, reporting the JZ modifier. If there was a wasted amount that had to be discarded, billing for that amount with the JW modifier. And claims without those modifiers will not be paid.
Interesting. Now, what about the bundling of radio tracers with the scan amount? Usually when CMS pays for a nuclear medicine or PET procedure, they bundle that tracer payment in with the actual payment for the scan. And now they're kind of saying, hey, we might be open to maybe breaking this open a little bit so the tracer payment is separate. Is that something that you see as beneficial?
Extremely, especially with the advent of highly expensive radiopharmaceuticals, Pylarify being one that comes to mind right away, that can be over $5,000 a dose.
And these radiopharmaceuticals are going to be really important now that we've got Alzheimer's therapies that appear to function. They actually work.
Correct.
At least in terms of amyloid reduction. Well, let's double back a little bit to the proposal to reduce physician payments by 3.36%. The AMA did an analysis, and they noted that since 2001, physician payments have fallen by 26%. And for some imaging services are down as much as 44%. Do those numbers sound right to you?
That sounds absolutely right. It's in line with other sources in the industry, with what RBMA is seeing, what other surveys have had published. And we are looking at, as I said, this year, not just a 3.36, but after the RVU adjustments, closer to 4.25. And that could be even higher for imaging centers, as most of the RVU cuts are in the technical component.
Now, so how much pressure is this putting on healthcare practices? What are you hearing from your clients?
It is putting a huge amount of pressure on radiology in particular, because radiology, as you highlighted earlier, has seen some of the largest cuts, and potentially facing a MIPS penalty as measures are eliminated. We have radiology in a tight job market with increased salary demand. We have inflation, rising teleradiology costs. Radiologists are really feeling like their backs are to the wall right now. And many of them are reaching out and trying to take action to advocate for change.
And so what change might that see? It sounds like there's been a call to reform the way that CMS does this process and maybe even get rid of this budget neutrality requirement.
Right.
What's happening at the congressional level?
Right now, there is at least one significant bill in circulation that would implement a Medicare Economic Index-based increase annually. That is H.R. 2474 and currently has 25 congressional co-sponsors. Obviously, RADPAC, which is the advocacy branch of ACR, RBMA, MGMA are leading the push to encourage that bill to be passed. And we are hopeful that since their past campaigns to mitigate cuts have been successful, we'll see progress here as well.
All right. Well, let's hope that happens. How can viewers get more information about what's going on in your analysis of the changes?
That's a great segue, Brian. At our blog, www.hapusa.com, within the next couple of days, we will be publishing a detailed blog article covering the major changes in the proposed rule. You can subscribe and stay on top of changes. You can look back at our June 5th article on how to help advocate for HR 2474. And of course, there will be a full update on the final rule when it's published later this year.
All right, very good. Well, something to look forward to. Sandy, thanks so much for being with us today. It was great talking to you again.
Great talking to you, Brian. Thanks.
All right, signing off for the Imaging Wire, my name is Brian Casey.